people that are like-minded. If you're meeting with physicians that understand that this is going to be a challenge, then we're able to eventually share the successes that we're all trying to achieve, especially with increasing the quality of care that we want to give. And again, some of the talks that we've heard earlier today really stress the importance that the patient drives this. There's so much that's happening in real time now, so much information that we're giving to patients, given to our staff, and so much happens in real time that, you know, it's kind of hard for them to get the buy-in that we want them to have so that we can achieve what we want to achieve. So it takes a really large group of people who kind of, what I say, who get the buy-in about this. The importance of knowing where your patient is, that's key to this, because you cannot manage when you don't know where the patient is, when they got to, arriving at the hospital, why they went. You know, that one of our successes has been trying to really educate patients about appropriate use of emergency rooms. You know, we're your primary doctor, as I like to call it, your personal physician, so that you contact us when there's time to plan visits and try to avoid the cost of emergency room visits. I'm going to break a little bit now because Mike has a very important innovative part of our innovative part of our team, and I'm going to have him talk a little bit about our proactive medication.
Dr. Charleton did a fantastic job of presenting CVCHiP as an ACO. I'd just also like to supplement what she was saying about Dr. Joseph. She is a pioneer in this and has, to the point that Brenda and Dr. Charleton, all the providers in CVCHiP know, she really was miraculous in her perseverance and resiliency to making sure that CVCHiP happened, and there are thousands of patients that have benefited from her hard work and the hard work of Brenda, and Brenda does a lot of things behind the scenes for the patients. And I mention this because it's an extraordinary effort to become an accountable care organization as a Medicare Shared Savings Program. It is a monumental effort, and Dr. Joseph and Dr. Charleton and Brenda, among others, have been able to really provide this for the patients and the providers, as she mentioned. I met Dr. Joseph in Richmond at her office, and there was a need around medication management. And as many of you know, medication management is one of the highest factors that not only has to do with patient care, with the expense built around healthcare costs, and we're all about the savings component of that with CVCHiP, but there's also a very high factor of admissions and readmissions due to contraindications through medications and prescribed medications in the emergency department, and then transition to care. What we've done with CVCHiP is and one of the things that CVCHiP as an accountable care organization does is partner with different service organizations to help provide the best care for the providers and their patients. And so C3 Healthcare RX was one of those partners, and what we've been able to do really is try and manage the medication management, the complex regimens primarily for patients with chronic disease states, comorbidities, and really for CVCHiP, the component is how do we reduce expense? How do we prevent emergency department admissions? How do we prevent readmissions due to many factors? What we're really focused on is the medication management. So for the providers, we have access, and I think that the slide is built around transitional care, but we have pharmacists who work directly with the patients and the providers. We actually even have pharmacists who work in the hospitals and work with the emergency department as soon as a patient is admitted. As you guys know, medication reconciliations are just a difficult thing to work through. And why? Because there are so many different prescriptions that may be filled at certain pharmacies and then held in certain EMRs, or between primary care providers and specialty providers. It's really difficult to manage medication. So what we do is we really try and pull all that together for the provider and the patient. And we actually do transitional care. So we actually have pharmacists in hospitals working with the physicians, but we also have certified pharmacy techs that help transition that patient from the hospital to the home, but also from a provider standpoint and those patients in terms of their medication regimen. So we'll actually have a certified pharmacy technician go into the patient's home, begin a medication reconciliation where we actually count all the medications and provide a list and send that to the providers. So in Dr. Joseph's case, we'll send that list to the provider and the different specialty physicians so everyone can see on one page, one piece of paper, what those patients are on. And obviously what this does then is it also allows the opportunity to reduce the number of medications and therefore, again, from an expense standpoint, really try and manage some shared savings for the ACO. So the challenge for the providers is that they need resources like this to help support that. We also have certified pharmacy techs that go into some of our patient or our practices and meet with the patients as they're coming in for their annual wellness visit, or they're coming in for their their visit for office care. So we're working directly with the physicians, the providers. We're working directly with the patients, all in an effort to really manage these medication regimens that are very complex. In many cases, we're working with patients. Believe it or not, we have patients on over 20 medications, and our goal is to back them off of that. And we can do that once we get all the physicians understanding, right, what's being prescribed by the different providers and the hospitals and the discharge, physicians as well. One other thing so the last thing I want to just mention before Dr. Charleton takes over is that, again, we have the transitional care approach, but we also are partnering and beginning to partner in several situations, but on the behavioral health and the mental health, specific areas of healthcare to really address some of the things that is related to cognitive impairment and that are related to certain mental health issues. And we're really trying to find the partners to be able to help us assist those patients where there are mental health issues and really getting them care, not only through the practices, but also different methods of care too, whether it be through technology and less intrusive methods that allow us to be able to reach those patients and work with them and their providers. So again, the big thing is that we're trying to get partnerships to work throughout the ACO, one, to improve care, two, to reduce it, or shared savings. I'm sorry.
Hospice and palliative care services, that's one of our future endeavors. Innovative culture, some of the practices are involved in evidence now, which is good for outcomes for patients. Also, there are reimbursable quality incentives in that program, and that's been a good rollout about a year ago for us. Again, improving, innovation, transforming, the idea that we can share the best practices, how we're going to get the best quality outcomes in how we're communicating to patients and getting their chronic condition. One of the things I found out in this whole process of the accountable care organization is if you are going to do something new to a patient, before someone shows up at their home about it, you've got to communicate with that patient. They are just, I say overwhelmed at all the people that are pulling against patients. And if you don't communicate with them, because we call this patient-centered, so we've got to remember that the patient is the focus of all of this. Incentives are good. Outcomes are good, grading physicians and other clinicians is good, but the patient is what is a focus. That's really what should drive all of this. So I found out that early on, if you kind of talk to the patients, let them know that somebody's coming to visit you, or that there's going to be something different about how your care is managed, they're much more apt to accept it. And actually, a call from their doctor, I can't tell you how many times patients say that you're really taking the time to call me. So, when we're bringing new things to them, I think that's one of the things that we want to do more of, to be sure that we remember to make sure the patient first knows that we're bringing something new to them. And certainly the benefits at some point, so this is our first reporting year. I will let Brenda talk about GPRO and many of the other things that she will tell you more in detail about. But it's important that we as physicians are telling one another, this deadline is happening. You know, you've got to, you know, we heard about the alphabet soup earlier, the MIPS is here, something else is out, meaningful use is gone, advancing care is here. Meeting those deadlines for reporting, just something like certifying your EHR, you don't want to leave those funds on the table because you missed the deadline. So a lot of what we do as, you know, an ACO is just to kind of give folks heads up on the deadlines that are coming. And we're hoping that we will meet our shared savings because we're going to be meeting things, meeting our deadlines, getting our quality data together and reported. We have a lot of things that we've learned in our first year or two of having to report. And again, this is part of the camaraderie that I appreciate so much. I have a small practice, the only physician in the inner city of Richmond. It was a historic practice that I was able to, fortunately, be able to come and take over. What patients will tell you is that I can get to you every day. I have open access. I can walk to you. I mean, the things that are important, but for us to, and I don't like the word survive, I like the word thrive, that for us to thrive in these changes, we have to band together as clinicians as well. So it's good that we have a platform that we can talk with one another, support one another, you know, and especially in a small group or a solo practitioner. The shared savings we will not know about, I don't think, until June. So that's something that we're hoping that we're going to be able to report about. But the idea is that I think we started with a little under 6,000 beneficiaries, maybe 36 different entities. So some are community health centers, some are maybe one or two groups, some are solo practitioners. We weight, you know, the ability to share the savings with CMS based on the number of patients involved. And again, the idea of having patients, CMS actually tells the patients when they are, in our case, in CVCHiP. But we also have to do a lot of patient education to tell them what it all means and what the outcomes are that, you know, we're trying to achieve for them. And it is Medicare for us, Part B, but we also have the same goals for all of them. Capitalized, well, we talked a little bit about we were not able to get the funds, but we do have an opportunity to add other physicians, other clinicians. I think it's January, to sign patients, to sign up other offices and clinicians now, but they will count in January.
How many of you are actually part of an ACO? Or yeah, she spent her Saturday with us last weekend. But how many of you? Okay, and
I was just going to ask if you could also speak to folks who are in our region who might be eligible for participation. It's not just in Central Virginia, and that we already have some practices from North Carolina.
Good afternoon. Dr. Lerna Joseph brought me on to this project. She is
real go-getter, absolutely an innovator in the field of healthcare. I mean, all those of you who know her, you know she's just like a little energized bunny. And she went from meeting to meeting, to house, to church, and pulpit to say, you know, if we can make $1, then we need to do this, because you never know what good things can come out of, even if it's just $5, you know, it can help your patients to improve. And it's a lot of work, but it's well worth it in the long run, because we've seen the growth of what's to come. And as you can see, macro, MIPS, and all of that is real, and it's not getting any shorter. It's getting, if anything, it's getting longer. And I guess by being at the innovative point where we had to do application upon application, and there are so many forms and criteria that we had to do to meet it. And actually, when she brought me aboard, we finally reached that threshold of 5,000 winnings, which we had to have in order to become an ACO. So once we reached that mark, then we began to go and try to make it further. So now we are Virginia and North Carolina, and we're in the Petersburg area. So we're Virginia, North Carolina, we're looking at, we have some practices, we're talking at other places. That's the good part about an ACO, it has no great geographic, really, boundary. It's all about the person or the operation that you have going. And we've been trying to have strategic meetings so that when we meet every quarter as a group, our governing board consists of our physician members or group members. And I know that all of you have gone to school. You know, it looks great to be in a group, but it also feels good to some to know that you can have that individuality and be able to maintain your what it is you love doing. And it's also good to know that we have other avenues. We function also as pretty much a medical service organization to our group, but we do it all as an integral part of the ACO. And in an ACO, there's a 3-year period. When you come on board, you sign on, and the actual beginning dates for each year would start at the calendar year in January. You go from the period of January to January. We have just done our first G-Pro reporting, and I did the lion's share of. We were required to do, as an ACO, we do that for every physician practice that's involved in our unit. We have a health information system which we use to gather our data through claims, pretty much. It's claims-based. However, I work with it individually with your practices and your office managers to develop them to the point where when their monthly claims come in, we know that we need to spiff up the LDLs, make sure your HbA1c's are in, make sure that all of the information that should be flowing into your EHR is in there. So when I pick it up, it'll all be there at the end of the year. So next year is going to be so great. It's going to all be integrated. I won't have to go and look for every patient out of our 8,000 patients like I did this year. So we will see how that goes next year. Also, it's very easy to sign up for ACO. It's just a matter of getting in the short paperwork and signing your contract. And we take it from there. Yeah, absolutely. We have a booth. We're working this weekend, Mike and Blair and myself, and we can sit down and talk with you about what it entails. We did it on $10 in a dream, and we're looking forward to making this thing happen. Thank you for your time.